So my name's Richard Russell. I'm a respiratory registrar. I'm currently on my ITU block here at the Glenfield. And Ricky Bell had asked me to do a teaching session on airways disease and asthma. To which I initially just said, yeah, that's fine, no problem at all. And then it was only afterwards I actually thought what I should talk about. And then I looked in the ICM curriculum and there's nothing at all about specific outcomes related to airways disease or asthma in the curriculum. And then I was trying to think about the stuff that's important to me to know about asthma is not the same stuff that's important for you guys to know about asthma. And actually, when it comes to ITU care for asthma, you guys will know a lot more about that than I do. So I wouldn't be the person really to be teaching you about that. So what I've tried to do is a little bit of a mishmash of a teaching session. Essentially, what I've tried to do is just pick out a few bits and pieces that I think are important that we both know about, essentially, that can have mutual benefits, if that makes sense. So things that we can do in our care in ITU, and also things that we do on the ward that can hopefully make everyone's lives a bit easier. It's not going to be a very long talk, so if there should be plenty of time for questions at the end, and I'm happy to take questions on whatever you want, essentially. So hopefully my slides will move. So what I thought I'd do, I'll just preface all this with a case, and it was coincidence really. So I'd written the slides about what I was going to talk about last weekend, and then we just happened to have a young lady admitted with asthma to the unit here this week, and a lot of her features of her disease were relevant to the things I was going to talk about. So I'll just quickly run through that case first, and then we'll make a start. So this is a 32-year-old lady, known background of asthma, and she was under the difficult asthma clinic here at Glenfield, but actually lived closer to Northampton, so a lot of her care was delivered through Northampton. For asthma services, we have this kind of hub and spoke setup, so they come here for their kind of tertiary level care, but we have a joint MDT, for example, with the Northampton team. So she's known to have allergic eosinophilic asthma with a background of frequent exacerbations, in the past having 3 or 4 hospital admissions at least per year. And for asthma, she'd been started on omalizumab or Xolair, which is anti-IgE therapy, about 6 months earlier. She was on long-term oral steroids. Previously, she'd been on about 11 or 12 milligrams of steroids and had managed to reduce it very slightly since starting omalizumab, and had some improvement in the exacerbation frequency since starting it as well. But in the background, there's also 3 previous ITU admissions, and 2 of which she was intubated and ventilated. However, we didn't have all the details of all those admissions because some of them, many of them, in fact, are at Northampton Hospital rather than here. She's also known to have vocal cord dysfunction, for which she's seen speech and language therapy, and breathing pattern disorder, for which she's seen specialist respiratory physiotherapy about in the past. So very typical of the patients that we see in the difficult asthma clinic. She had background of Ehlers-Danlos syndrome as well, and there is associations between Ehlers-Danlos and airways diseases, also POTS, migraines, and she'd had an ASD repair in the past. She was on, I think, about 28 or 29 different medications, which is a lot for a 32-year-old. Related to her asthma, she was on high strength Foster, so Foster 206, which is the highest strength, Spiriva, which is tiotropium, Montelukast, which is leukotriene receptor antagonist, maintenance prednisolone. She's also on azithromycin, low dose 3 times weekly, which is given for both its antibacterial prophylactic properties, but also its anti-inflammatory properties are beneficial in asthma as well. And the Xolair, as we mentioned earlier on. And of note, she was intolerant to aminophylline. She'd previously gone into SVT whilst on an aminophylline infusion, and therefore it is avoided now. So the background to this admission, she had kind of viral coryzal symptoms for about 4 days, which had actually improved by the time she came to hospital. Her daughter, school-aged daughter, had also been ill with the same symptoms last week. She then had 2 days where her asthma symptoms worsened. So even though the coryzal symptoms were improving, the peak flow was dropping, she was more tight-chested, and she developed more of a cough than normal. But she actually didn't do anything about it at home. She was due to come for her Xolair injection in the clinic on Tuesday, so she just waited until then because she knew she'd get to see someone from the asthma team. When she was seen in the clinic, she had a peak flow of 220 off a baseline. Her best is 400 litres per minute, which is only 55% of predicted, and looked unwell, so they admitted her from Xolair clinic straight to CDU. That's our admissions ward. The team in CDU gave her back-to-back nebs, some ipratropium nebs. She'd had 40 milligrams of prednisolone at home on that morning, but they still gave her 200 milligrams of hydrocortisone on top of that. She had IV magnesium and meropenem, and on review after all that, she was still looking not very well. There was concerns that she looked like she was tiring, and her blood gas at that point had a CO2 of about, I think, 5.6, so kind of high normal blood gas. And based on that, she was referred for ITU review here, and was brought up to ITU, essentially. So on arrival in ITU, she was actually quite a lot better on arrival in ITU than she had looked on CDU. So respirator was 18, heart rate was 90, blood pressure was normal and saturating well on 4 litres of oxygen. She was able to speak short sentences, and on a chest examination she had polyphonic wheeze both sides with lots of transmitted upper airway sounds as well. Blood results are not particularly exciting. CRP was only 14 and her blood eosinophil count was normal. She had a chest X-ray which showed some minor left lower lobe changes which were long-standing from previous imaging that we had. We knew they hadn't changed. And then her ABGs you can see there. So the one in CDU with a CO2 of about 5.6. And then on arrival in ITU, she had another blood gas sent which was much better. CO2 had gone down essentially, and she was less kind of borderline hypoxia. PO2 was much better. So at that point it was thought she's improved or improving from the treatment that had already been given in CDU. She was unlikely to need intubation and ventilation. So we give her regular nebulizers, steroids for 40 milligrams prednisolone for 7 days, not forgetting that she's on long term to follow that. And importantly prescribed her usual asthma medications as well, and I'll come back to that later on. There wasn't really much evidence of infection in either her symptoms or signs or blood tests, so we stopped the meropenem and then to wean off oxygen and monitor her peak flow. And then by the following day, she was much better. So her chest was then clear on examination. Peak flow picked up a little bit, but not hugely. A swab came back to confirm that she had rhinovirus, which fits with the story of viral prodrome. But she was well enough then to switch the nebs to PRN, restart her usual Spiriva, and aim for a step down bed to the ward. And we also set criteria for discharge at that point in time because she needed a side room whilst awaiting MRSA swabs, and there's no side rooms on the respiratory ward, so we thought there was a chance she could actually end up in ITU for the whole of her admission. So that was the case, and there's a few of those elements that we'll come back to during the talk. Essentially, I'll just start by giving a little bit of epidemiology, but also trying to bring that specific to ITU. So just for context, globally about 3.5% of the population are diagnosed with asthma. It is more prevalent in high income countries. So across Europe, for example, it's about 6%. But within that, there are pockets that are very high. So, for example, if you live in far northeast Finland and you do cross-country skiing, you've probably got about a 30% chance of having asthma. Within the UK, prevalence estimates, which are just based on GP prescriptions for asthma treatment, show that about 5.4 million people are on treatment for asthma. Now that's probably a reasonable guess, but it's not a perfect reflection because there will be many people out there with asthma that are not diagnosed and not on treatment, and equally there'll be many people that have been prescribed a salbutamol inhaler at some point for some kind of wheezy viral illness that actually don't have asthma. There's about 75,000 asthma admissions to hospital in the UK per year, and within England and Wales about 1,400 of them end up on a critical care setting. Roughly half of those patients are ventilated, but there's pretty good survival, so it's only a 5% mortality, and the other 95% are discharged from the ITU. Now, Estimates for asthma deaths. The most recent data we've got is from 2017, show there's about 1,300 deaths per year, roughly. Although the way that's collected isn't perfect. But the more astute amongst you might have noticed there that if there's only 1,400 asthma admissions to critical care and there's only 5% mortality, that's only 70 patients annually that will be dying in an ITU setting. So the other 1,250 are dying elsewhere. This just tells you a little bit about the change in death rate over time in different age groups, and you can see that the mortality rate from asthma is improving for almost everybody except older people. So people over the age of 75 in that top blue line, mortality hasn't really shifted in the last sort of 40 years, to be honest, when every other group has. And there's probably various reasons for that, and I suspect a lot of that is deaths being coded as asthma deaths that are perhaps not in more elderly people that are more likely to die of other respiratory complaints. Now we had a national review of asthma deaths back in 2013-14 when concerns have been raised about the mortality rate from asthma within the UK, because we sort of consider it within the respiratory community that every asthma death should in theory be avoidable. So to have over 1,000 people a year dying with asthma is a big concern. So I've just picked out a few of the key findings from that report. So they looked at, essentially they audited in great detail all of the asthma deaths for a 12-month period. And by great detail, I mean they did things like not just look at all the notes and records and OBS and investigations, but they even looked at things like pollution levels in the environment on the days they were admitted to hospital, what the weather was doing, staffing levels on the hospital on the day they were admitted. You know, they looked at literally everything. And this is what they found. So first of all, you know, 45% of those that died without seeking medical help or before it arrived. So this is just highlights really that many asthma deaths are a pre-hospital problem, and us as hospital teams, there's limited amounts that we can do acutely to try and address that. You know, there's other things that can be done in the long-term care, but acutely there's not, you know, much we can do about that. 57% weren't under secondary care in the last 12 months. But 47% had previous hospital admissions for asthma, of which 21% had attended the emergency department at least once in the last 12 months due to asthma. Of probably more concern, 10% died within 28 days of discharge from hospital with an asthma exacerbation. And that's why we've now got much more fixed and set criteria about safe discharge with asthma. Only 23% had what we call a personal asthma action plan, which is something that's already been shown, even at this point in time, to be beneficial in terms of preventing asthma exacerbations and asthma deaths. And that's basically just a personalised guide that each asthma patient has that tells them what to do in terms of treating their asthma if their symptoms worsen. 43% hadn't even had an asthma review in primary care in the last 12 months, and there are sequins and things attached to this, so that's a bit of a worry as well. But interestingly, in terms of the asthma severity, it wasn't all the severe asthmatics that were dying. In fact, almost 60% were mild and moderate asthmatics. So it's not just something that can be necessarily addressed by just targeting severe asthma clinics, for example. And then finally, they also looked at the prescriptions that these patients had received in the preceding 12 months before death. Now, when we look at short-acting bronchodilator prescriptions, we use one inhaler per month as a kind of a maximum permittable prescription, essentially, before you start to get a bit concerned. So anyone that's having more than 12 SABAs in a year is diagnosed as having uncontrolled asthma, and that should prompt a review, really, an increase in the maintenance care. So nearly 4 in 10 were in that category, but you know, so 4% of this population had collected more than 50 salbutamol inhalers in the preceding 12 months. So that's going through an inhaler a week. On the flip side, the reliever inhalers, the ones that are actually proven to keep people well and out of hospital, 80% had picked up less than one a month, and it should be that your reliever inhaler lasts 30 days. So 80% of them weren't picking up enough reliever medication, and worryingly, you know, 4 out of 10 were only on about a third of the amount of reliever medication they were actually prescribed in terms of what they were picking up. And that's only picking it up. We don't know what happens to it when he gets home. They could just put it straight in the bin. So there was all sorts of recommendations made on the basis of this report. And then the idea was to look back at this to see if it's changed, but that hasn't happened yet for various reasons. I think it was actually due to happen around the time that the pandemic hit, but they've obviously deferred that. So just very briefly, in terms of what happens with an asthma exacerbation. So you may be familiar that there's kind of different subtypes of asthma that we call phenotypes, which I've kind of picked a few of the common ones here. So most of the time when we're talking about asthma, we're talking about allergic and eosinophilic asthma, which is the ones on this side here, which you can see. So allergic eosinophilic asthma typically in response to an allergen, inhaled allergen in the airway. The airway itself is damaged, but there's lots of pro-inflammatory cells and cytokines and things that get upregulated in response to that allergen. And the end result of that is you get eosinophils migrating into the airway wall, into the airway smooth muscle. And that's what causes the increase in mucus production, it causes the bronchoconstriction, and it causes the cough and the symptoms. Similarly, you can get eosinophilic asthma that's non-allergic, and that's usually related to viral infection is by far the most common cause in that group. Slightly different pathways, but very similar kind of inflammatory process. Then there's less commonly non-eosinophilic asthma, those that have lots of neutrophilic inflammation and often have things like bronchiectasis alongside this and lots of bacterial infections. And then those that don't really have any predominant inflammatory profile, which is probably due to pollutants and airway epithelial damage that causes them to get asthma symptoms. What does that actually end up meaning for the patient? Well, you can see here on the right, this is what the airway of a chronic asthmatic might look like. So they've got proliferation of the smooth muscle, lots of fibrotic cells deposited within the subepithelium, lots of mucus, abnormal epithelium with lots of goblet cells. And then in the acute exacerbation state, a lot of that kind of kicks off essentially. So the goblet cells make lots and lots more mucus. That's why patients get lots more mucus. You'll often find asthmatics will have a lot of mucus even if they haven't got infection, and it's just mucus full of inflammatory cytokines and inflammatory cells essentially. And then you obviously get contraction of the airway smooth muscle, which is what gives the bronchospasm. And there's a few cytokines that are very key to this process, and we'll briefly mention them later on. And the end result of all this is that during an asthma attack or exacerbation, you get a very narrowed airway, really tight constricted bronchial airway smooth muscle, lots of mucus in the airways, and the result of that is that you get gas trapping. So dynamic hyperinflation and gas trapping, leading to problems with ventilation and ventilatory mechanics as well. Now there are very well known predictors of exacerbations, which are worth knowing about when you're assessing a patient in terms of deciding their risk. But the biggest one in terms of predicting the risk of exacerbation is previous exacerbations, which makes sense. But it's worth knowing because, I mean, I come across this phenomena on the respiratory wards, and I'm sure it's the same in the ITU setting, that it'll often be the same names and same faces that come through the ITU unit frequently. And it can be very easy, I think, to kind of pigeonhole those patients perhaps as being maybe those that don't take the treatment properly, or that they come to ITU when they don't need to, for example. But actually it's not always preventable. It's just a feature of their disease. If you have exacerbations, you will have more exacerbations. And there's also some well-defined risk factors for the type of asthma or exacerbations that are likely to end up in the intensive care unit. And you can see the top of the list again is previous severe and near fatal asthma exacerbations, especially if you've been ventilated. That in itself is the biggest risk factor for future exacerbations. There's also other things to do, if the more asthma medication you're on, for example, the more high risk you are, the more short-acting bronchodilators that you use, repeated NSAID, all the stuff you would expect in terms of predicting your risk. But then there's lots of behavioural and psychosocial factors that are worth knowing about as well, especially if you're assessing patients in the emergency department, because patients that, for example, fail to attend appointments, have previously self-discharged from home, have history from hospital, have history of mental health illness, for example, social factors such as alcohol and drug abuse, employment issues, social isolation. These are all shown to have very clear risk prediction in terms of that patient having a poor outcome from their asthma exacerbation. So it's worth knowing that, I think, in terms of when deciding thresholds for admission to an intensive care unit, essentially. Okay, so what I thought I'd just briefly run through is some of the pharmacotherapy that is given everywhere for asthma, but there's a few things I want to just pull out really that I suspect are not always thought about in the ITU setting, and I'll explain why I think they're important. So obviously we know that we give steroids for people with asthma exacerbations. That's the key thing that's going to actually address the inflammation and get them better. There's no benefit at all between giving intravenous hydrocortisone compared to prednisolone, so if they can swallow oral tablets, give it orally. Bronchodilator, nebulized if the patient's able to have nebulizers. If not, you can always give salbutamol intravenously. 2.5 milligrams of salbutamol is perfectly fine, rather than 5 milligrams. The rest of the other 2.5 milligrams normally ends up all over their face. It's probably better to give 2.5 milligrams more regularly than it is to give 5 milligrams QDS. Magnesium sulfate, obviously everyone will be very familiar with. The evidence that it makes a huge difference is not great, but it's pretty safe and doesn't really cause any harm, so it's worth giving anyway. Same for aminophylline, really. There's not really a huge body of evidence that it makes a big difference, but there are a subtype of patients out there that do respond to it very well in terms of bronchodilator response. So again, it's always worth trying if there's a patient that's struggling and has very tight wheeze. Now, the things that perhaps don't always get picked up on and given in the intensive care unit relates to the usual asthma medications that patient takes. So if you've got an awake patient, no matter what setting they're in, and even if you're given high-dose oral steroids and nebulized salbutamol, for example, it's always a really good idea to try and give their regular inhaler, particularly the ICS, which will often be in combination with a LABA, so something like Foster, for example. If they know how to use an aero chamber and their normal asthma inhaler is a metered dose inhaler that can use with an aero chamber, then you can still give that even if they're very, very severely breathless. So you can just do tidal breathing through an aero chamber and dose through that. Obviously, if they're on a dry powder inhaler, that you take those with a short, sharp breath in, and many asthmatics during exacerbation won't be able to do that. So don't switch them just for the purposes of giving something if they're on a dry powder inhaler. But most patients will be on an MDI with a chamber, and it's important to still give them that while they're unwell. There's a small amount of evidence to show that when they stop oral steroids, there's a lower chance of rebound if they've continued their inhaled ICS during the admission. But also from our perspective, in terms of looking after the patients in the long term, it just reinforces to them the importance of their regular treatment, because it's not uncommon to find patients that don't take their inhalers because they don't think they do very much, and that is reinforced by the fact that when they come into the hospital, they get stopped. They come in unwell, and actually you just give me steroid tablets and nebulizer, so why can't I have steroid tablets and a nebulizer at home? So it just reinforces that. So that would be a really useful kind of take-home message from this, essentially. And obviously you only need to give antibiotics if there's a suspicious bacterial infection. We don't give them blanket. Obviously, once the wheeze starts to settle, you can switch the nebs to PRN. Again, you can give salbutamol via an aero chamber, 2 to 10 puffs. About 8 to 10 puffs is probably equivalent dosing to 2.5 milligrams of nebulized salbutamol. And again, it just reinforces that they can use their MDI via aero chamber during exacerbation periods as well. You only need to give a tapering course of steroids if the acute course is more than 14 days. We audited this recently in the respiratory department, and we do appallingly badly. So about 60% of patients that had given a tapering course of steroids, it wasn't indicated based on the guidelines. But obviously, if they're on maintenance steroids, don't forget to restart them. Okay, I told you this would be jumping all over the place. just wanted to say something about biologics. This is actually what I was talking to Ricky Bell about, that was kind of prompted this talk. He was saying that they don't really know anything about the biologics that have come through. There's been quite a few recently, and they don't know what to do if they have patients on them. So just one slide, very briefly summarising. So these are the current licensed biologics in the UK. So we've got omalizumab, which has been around for quite a long time now, which is anti-IgE therapy. That's been around for about 10 to 15 years. And more recently, we've had therapies that address interleukin-5. And the job of interleukin-5 in that diagram I showed you earlier on is essentially it recruits eosinophils. Well, it stimulates your bone marrow to make more eosinophils. It then recruits them to the lungs, and it causes them to mature faster into active eosinophils. So you can give IL-5 therapy to reduce eosinophilic burden, and there's good evidence that it works. So this is from a paper done here at Leicester by Pranab Haldar that shows that patients given mepolizumab, it reduced their exacerbations over 12 months by half. So there's 3 drugs currently licensed for the IL-5 pathway, and there's a couple of others that are probably very shortly to get licensed, addressing slightly different parts of the inflammatory cascade. But essentially, they're all administered subcutaneously, except for reslizumab, which is intravenous, about every 2 to 8 weeks. It varies depending on the drug, but also on patient factors such as weight as well for some of them. There was initially concerns that they might be immunosuppressive and increase people's risk of infection. So there was some hesitancy initially about giving them when people were unwell, especially with an infective exacerbation, but follow-up data and bigger studies have shown that's not the case. So they're not significantly immunosuppressive. In fact, they're less immunosuppressive than 40 milligrams of prednisolone. So the take-home message from this slide is that if you're looking after a patient in the intensive care unit who's on one of these medicines and it's due to be given, it can still be given. And actually, it will probably benefit their recovery, because there is a bit of a wearing off effect at the end of the dosing period for many of these, and you start to notice a slight drift in the eosinophils back up. So if they're in with an asthma exacerbation, actually giving strong anti-eosinophil medication is probably useful. So you can just contact the severe asthma nurses and they will come and give the medicine on the ITU. Just very briefly to mention a few of the asthma mimics or asthma-associated conditions, which I think is a better way of thinking of them. So this is by no means a complete list, but this is probably the top 3 things that we see. And the patient from the case had a couple of these as well, probably all 3, actually. So these are conditions that are very commonly diagnosed alongside asthma and can mimic and confuse the symptoms and the presentation of an asthma exacerbation. We know that psychosocial factors, particularly mental health problems, are correlated with bad outcomes in asthma in terms of your chance of being admitted to hospital and ending up in ITU. Some of that is probably related to things that happen at home outside of hospital, such as adherence to maintenance therapy. But anxiety and panic attacks can often look like an asthma exacerbation. Vocal cord dysfunction, I'm sure you'll all be very familiar with. So, abnormal closing of the vocal cords during the respiratory cycle. That can look very dramatic from the end of the bed. And when you've got a patient with known severe asthma that's previously been in ITU with asthma exacerbations, that's having a worsening of their vocal cord dysfunction, it can look almost identical to an asthma exacerbation. And I think the patient that we mentioned in the case, I think, did have an element of this. And then breathing pattern disorder, or dysfunctional breathing as it used to be called. Probably breathing pattern disorder is probably the preferred term now. Again, it's very common in anyone that has a chronic respiratory disease, really, because they're just more aware of their breathing, and the control mechanisms for a normal breathing pattern become altered. And again, that can flare up from time to time, especially during an exacerbation episode, and confuse and muddy the water in terms of their symptoms and improvement and assessment. The key kind of thing I wanted to stress about these is that, yes, they're very difficult to differentiate from asthma, but in someone that's got known asthma, presenting with these as well, very often it's much safer to err on the side of caution and assume it's asthma and treat it as asthma. There's nothing that we can do about any of these in the acute setting during an asthma exacerbation. You're not going to be able to cure someone's breathing pattern disorder during a hospital admission. So it's worth acknowledging they are there. Sometimes if it's very severe and it's slowing down a discharge, for example, we sometimes get the physios to see and start the treatment for breathing pattern disorder, but these are things that are fixed over a prolonged period of time in the outpatient setting. But they are genuine pathologies, and patients often tell us when they come back to clinic that what they were told in the past or when they're in hospital was that it was all in their head, and that these things were dismissed as being them playing up essentially, and that's not the case. They are genuine pathologies, and acknowledge them, accept that they're there, but try not to play them down when you talk to the patient essentially. Almost finished. So just one final little plea from our perspective. So sometimes when we're discussing severe asthmatics in the asthma MDT and we're trying to work out what the next best step in their care is, and like I said, many of these patients will have things like vocal cord dysfunction. Many of them will have been admitted to ITU and ventilated in the past. One of the things that we can sometimes use is trying to work out whether when they were ventilated, whether they were easy to ventilate or not. And that's something that often we struggle to find in the ITU documentation, and it can actually be really useful in terms of us deciding the next steps in someone's care. So this is just a general plea really. If you've got an asthmatic that gets intubated and ventilated, whether it's on the discharge letter or somewhere very clearly, it's worth just documenting how easy or difficult it was to ventilate them, because if they were very difficult to ventilate, then that focuses us more on dealing with the asthma and the bronchodilator side of things, whereas if suddenly all the symptoms melted away and they're very, very easy to ventilate and were extubated 12 hours later, then that might point towards something like a vocal cord problem. And I didn't have this slide in until it looked like we might be discharging the lady in the case directly from the ITU, potentially, if there was no respiratory beds. So it's just very briefly to mention, these were some of the things that came out from the National Review of Asthma Deaths about potential discharge criteria. So obviously patients need to be independent self-caring. We take a threshold of 24 hours that they need to be off all nebulizers. That includes PRN nebulizers, because a small proportion of patients will relapse within that 24-hour period. And it's best if they do that in hospital rather than at home. The peak flow should be more than 75% of their best, or if they don't know their best, their predicted value. And they should have had their inhaler technique checked, and they should all have a personalized asthma action plan. And if they don't already have one, you can give these yourself. So this is one you can just download and print out from the Asthma UK website. You have to fill in a few boxes about what inhalers they take and when they should take a course of steroids, for example. And typically they're all broken down into 3 sections. On the left is all about, in green, about what they normally take. The yellow is when the symptoms start to deteriorate and they probably need to start taking oral steroids at home. And on the red is things that they should do if things get so bad they need to come to hospital. And you can just give them advice in terms of things like if the peak flow drops below, then give them a number there. So often we use, for example, 70%. Drops below 70% of their best, that's when they should start taking steroids. If it drops below 50% of their best, that's when they should come to hospital. We have severe asthma nurses. They only do these reviews in the Glenfield, unfortunately, but you can refer on ICE and they will do the vast majority of this stuff for you before the patient goes home. Now, the guidelines suggest that patients should have a GP appointment within 48 hours of discharge, which seems, well, actually, to be honest, I always thought that seemed ridiculously impossible. And so I usually tell people anytime within the next week was probably okay. But actually, I saw a presentation at a conference a while ago, and the GPs do remarkably well at this, actually, following up patients within 48 hours. So that's what patients should be told. After hospital admission, they should all be seen in the respiratory clinic. So if you do discharge anyone directly from the ITU setting, do just make sure that they're referred to us if they're not already under our care, and make sure they've got a peak flow meter at home to measure their peak flow. And that's all I was going to say, really. So in summary, most asthma mortality is actually not in the ITU. If patients come to ITU, they tend to do pretty well. But while they're here, in terms of helping their care in the future, it's good to keep their normal kind of asthma care going as well. And that helps reinforce the importance of their normal asthma treatment. Any patients on biologics, they can be continued and given in the ITU setting, and you don't have to worry about immunosuppression. Associated conditions are not going to be fixed while they're in ITU, so to accept they are there, but try not to worry too much about them. And then, as I said, it's useful for us if you can let us know how easy or difficult they were to ventilate. Okay, any questions? Don't know what time it is. Yeah, about half an hour or so. Any questions?
Start biologics? Is it when new medication is or is it
yeah. So there's a question in this end. Sorry, it's when do we start biologics? Was the question. Yeah. So each biologic has slightly different criteria for it. Broadly, they have to be exacerbating. So it's usually 4 exacerbations in the preceding 12 months. They have to be shown to be adherent with the rest of the asthma medication, and that's all been optimized. And then the other criteria depend on what the drug is. So if it's anti-IgE, we check the total IgE level. It has to be within certain thresholds, and they have to have sensitivity either on skin prick test or on RAS test to a common air or allergen, like house dust mite, for example. The IL-5 ones is otherwise it's about the eosinophil count. So they have to have an eosinophil count above a certain threshold. It varies slightly between the drugs, but usually 0.3, 0.4, something like that. Any other questions from anybody about anything? Can be anything to do with asthma, not necessarily what I've talked about.
Yes, can I ask something?
Sure.
Since you're at Glenfield, and I don't know if there is any of the ECMO consultants there, anything, like about some data regarding ECMO and asthma, I don't know, like long-term outcomes and stuff. That's the question.
Yeah, so none of the ECMO consultants are here.
Okay.
Well, they do write most of the time, and most of the consultants, they are encouraged to get the asthma patients and commit them to ECMO. The only problem with it needs to be very cautious because clearing CO2 very quickly may get intracranial bleed from acute in the intracranial space. But surprisingly, there was an interesting case that we received in the last week or the week before. She was referred to 29-year-old, but was investigating her baseline. She was, and the letters that you mentioned from her GP and from the difficult asthma clinic, last letter I mentioned, I tried everything with this lady. I don't know what to do with her. And her post-expiratory volume 1 was decreasing since 2018, and it's not quitting off since then. So they elected to treat her conventionally. The only thing that I learned from that case that sometimes we may take the patients with acute asthma to theatre, or sometimes use something called anaconda to give them volatiles, like volatile anesthetics, and this may help with acute asthma. This is something that is not mentioned with the respiratory physicians, but is very helpful with this. And she was managed well with just conventional management.
Could you hear that at that end?
More or less.
Yeah. Good. So the crux of it was that they seem to do well, mostly.
Okay. Yeah.
As long as you're cautious about the rate of CO2 removal.
Yeah.
Thank you very much. I hope that was useful. Like I said, I felt ridiculous trying to come and teach you about kind of ventilation strategies and ITU drugs and stuff, things like ketamine that you might give and stuff when I don't do that stuff. So I hope that was useful in some way. I think we've got a journal club presentation now as well.
Hi, my name is Stan May. I'm one of the ST5 trainees here, intensive care medicine, and I'm doing cardiac ICU rotation at Glenfield at the moment. So the article for today's discussion is the article which is it is basically a meta-analysis which was basically published in Journal of Critical Care in 2022, and this is basically the association between the timing of intubation and the clinical outcomes, especially comparing the early intubation and a late intubation. So yeah, so it's meta-analysis to investigate the association of timing, intubation, and clinical outcomes. So early, it's always a clinical debate. What is the ideal timing of intubation? Because we need many times we need to weigh the risk which is associated with early intubation, um, or or basically whether we need to wait and watch to see, because if we are planning to do early intubation, which can actually prevent self-inflicted lung injuries, and the risks which are associated with early intubation could be airway injuries, cardiac arrest, ventricular associated pneumonia, and need for sedation. So the methods they used in this study, which was basically they did an independent research, which is done by two authors. They did a research on PubMed. So they have selected the articles from different countries, from Africa, Asia, Australia, Europe, North, South America. So the inclusion criteria of the study was both observational studies and randomized control trial. And they basically compare the mortality of critically ill patient undergoing early versus late intubation. So the exclusion criteria of the studies were they have excluded new COVID disease patients and pediatric patients from the study. They defined early intubation as an intubation which is occurring within 24 hours of ICU admission, and late intubation which is occurring after 24 hours of ICU admission. So the final data was collected from 27 studies. So overall, if we see they shortlisted around 302 articles from PubMed, and there were only 27 studies finally, which was included in the meta-analysis. And out of these 27 studies, 24 were observational studies, and 3 were randomized controlled trial. So if we go back to the primary outcome that they decided for in the meta-analysis was all-cause mortality, and the secondary outcome was length of ICU stay, duration of mechanical ventilation, or need of vasopressors, or need for any renal support. So these are the different studies which have been taken from the different countries: Brazil, France, Taiwan, Brazil, and Italy. The results of the study of the primary outcome was all-cause mortality, which was lower in the patient going early versus late intubation. So there were 7,338 deaths, which were 45.8% in early intubation versus 53.5% in late intubation a patient. So relative risk was 0.92, and the p-value was 0.001. So the results, they also did a sensitivity analysis, because in all of these studies, 27 studies, many of the studies they have not defined what do they mean by early intubation. So there were few studies only in which they have defined early intubation, which is less than 24 hours from ICU admission. So they did in those patients in which in those studies in which they have defined the early intubation timing, they did a sensitivity analysis, and which also they found that the result is consistent, that early intubation has got lower mortality versus late intubation. And this was a consistent finding when they did the subgroup analysis in the patient with immunocompetent state observational studies and the studies with low risk of bias. So this is basically the numbers which is showing the all-cause mortality in all the 27 studies. So if you see here, so the total number of patients is around 15,000. So this on the left side, this number is 11,943. So they intubated. These are the patients who went early intubation, and 3,498 patients who went late intubation. So if we see the number, so out of this 11,943 patients, the deaths were 5,467, and in the patients who were intubated lately, the deaths were 1,871. So the total overall, the p-value of the test was is 0.0010. So this is the sensitivity analysis that they have done in the limited studies, in which the definition of early intubation was there. So they found that in this also the results were consistent with the p-value 0.005 and the risk ratio of 0.93. So the secondary outcome was based on the data of 3 studies, which shows the ICU length of stay was shorter in the patient undergoing early versus late intubation. What was the limitation of this meta-analysis? So again, the main limitation was definition of early intubation, which was not defined in most of the studies. However, since they did a sensitivity analysis in that subgroup, so they found that the results were consistent in both in the main analysis and the sensitive analysis. And also the timing of intubation and outcome, they say that maybe which could be confounded by other factors like many patients that initially they have tried with non-invasive ventilation or high flow oxygenation prior to intubation. And lastly, they also acknowledged that the search they did was not a complete search. They just did a search on PubMed. They could have expanded their search to Scopus, Embase, or Cochrane. So the conclusion of the meta-analysis was they incorporated around 15,441 critically ill patients from 27 studies, and they found that all-cause mortality was lower in the patients who were undergoing early versus late intubation. And this finding also suggests that avoiding late intubation may be associated with lower mortality in critically ill patient without COVID-19 infection. Any questions?
So why they define the early intubation as the intubation in the first 24 hours? Because sometimes the early intubation is the early intubation in the case that like they have someone maybe ill, then over the course of the ICU or something like that. It's not early all the time. There's 24 hours, first 24 hours.
I think in order to get the study done, they should have a definition. I mean, and that's why I think I don't know whether they what is the reason why they have chosen like 24 hours as early definition. I don't know the exact reason, but I think in order to do in order to compare it, you should have a definition that.
Yeah, I know, but just sometimes the patient post operative report me later on 5 to 6 days he developed a flap. So if he's intubated at that time, they would be considered as there's some sort of bias in this study. And I think one other big point that is included lots of symptoms that has different criteria for selection of patients. Like some symptoms like here has a strict selection criteria for patients who may be successfully weaned or a candidate for successful weaning from invasive ventilation. Sometimes not. So yeah.
No, I mean you're right actually, because they also think that deciding about intubation is not only clinical, it also depends on the personal and the departmental, what is the departmental policy. So it's variable, but they try to maybe they try to put a number and just find that and also like it's it's difficult to compare if you take like particular terms of mortality. So that's why they have taken all-cause mortality, just to wrap up things around. Any questions? Thank you for listening to me. Thank you.